Hello everyone. This recorded lecture is about the pathology of the respiratory system. But before we proceed, let's have a short review about its anatomy and physiology. The respiratory system is responsible for two major functions, ventilation and diffusion. The ventilation involves the movement of air in and out of the lungs, and the diffusion relates to the gas exchange between the lungs and the circulatory system. This system is usually subdivided into the upper respiratory tract, which is the nose, mouth, pharynx, and larynx, and the lower respiratory tract, which is trachea, bronchi, alveoli, and lungs. The thoracic cavity consists of the right and left pleural cavities and the mediastinum. The parietal pleura lines the thoracic cavity, and the visceral pleura adheres directly to the lung tissue. Now let's start with its pathologies. Cystic fibrosis is one of the congenital and hereditary conditions of the respiratory system. It is a generalized disorder resulting from a genetic defect transmitted as an autosomal recessive gene that affects the function of exocrine glands. Cystic fibrosis is the dehydration of the mucus layer and leads to an accumulation of viscous secretions that obstruct the airway. Pulmonary damage is initiated by gradually increasing secretions from the hypertrophy of bronchial glands, leading to obstruction of the bronchial system. The resultant plugging promotes staphylococcal infection, followed by more tissue damage as well as atelectasis and emphysema. The signs and symptoms of cystic fibrosis usually include a chronic cough and wheezing associated with recurrent or chronic pulmonary infections. The cough is often accompanied by sputum, gagging, vomiting, and disturbed sleep. Barrel chest deformity, clubbing of fingers, and cyanosis occur as the disease progresses. In adolescents and adults, pulmonary complications associated with cystic fibrosis include pneumothorax, hemoptysis, and right-sided heart failure secondary to pulmonary hypertension. Chest radiography aids in the diagnosis of cystic fibrosis. Early changes of bronchial thickening and hyperinflation progress to extensive bronchiectasis, cyst formation, lobar atelectasis, scarring, pulmonary artery and right ventricular enlargement, and overinflation of the lung and chest wall. Treatment methods include antimicrobial drugs to combat infection, bronchodilators administered through inhalers, respiratory physical therapy, and in some cases, a lung transplant may be performed in patients with end-stage lung disease. Next condition is the hyaline membrane disease, also known as respiratory distress syndrome. It affects infants and it is a disorder of premature infants or those born at less than a 37-week gestation. Incomplete maturation of the type 2 alveolar cells within the surfactant-producing system causes unstable alveoli, which is the structures in which gas exchanges occur in the lungs. Infants are particularly in need of a low surface tension in the alveoli, and surfactant provides this. Its deficiency results in alveolar collapse with widespread atelectasis. When an increased risk is assumed prior to birth, corticosteroid drugs may be administered to the mother before delivery. The signs of RDS include rapid and labored breathing within the first 24 hours after delivery, with the atelectasis and respiratory failure progressively worsening. Chest radiography demonstrates severe atelectasis with an air bronchogram sign characterized by bronchi surrounded by non-irritated alveoli. Treatment consists of maintenance of a proper thermal environment and satisfactory levels of tissue oxygenation, which is monitored frequently via ABG measurement. Now let us proceed with the inflammatory diseases, and first is pneumonia. It is the most frequent type of lung infection, resulting in an inflammation of the lung and compromised pulmonary function. The main causes of pneumonia are bacteria, viruses, and mycoplasmas. In adults, bacteria such as Streptococcus pneumonia, Staphylococcus aureus, Haemophilus, H. influenza, and Legionella pneumophila are the most common causes of typical pneumonia. Chlamydia pneumonia and Mycoplasma pneumonia are common causes of atypical pneumonia in adolescents and young adults. Atypical pneumonias present less obvious radiographic signs compared with typical bacterial pneumonias. Viral pathogens such as influenza virus, parainfluenza virus, adenovirus, and respiratory syncytial virus may cause pneumonias. The inflammation may affect the entire lobe of a lung, called lobar pneumonia, a segment of a lung, called segmental pneumonia, the bronchi and associated alveoli, called bronchopneumonia, or interstitial lung tissue, called interstitial pneumonia. Chest radiography is important in determining the location of inflammation, with the pneumonias appearing as soft, patchy, ill-defined alveolar infiltrates or pulmonary densities. Symptoms associated with pneumonia include a cough, fever, and sputum production, usually developing over days. Individuals with pneumonia often exhibit tachypnea, and on physical evaluation, crackles may be heard in conjunction with bronchial breath sounds. Next is bronchiectasis, a permanent abnormal dilatation of one or more large bronchi as a result of destruction of the elastic and muscular components of the bronchial wall. The basic pathogenesis is either congenital or acquired weakness, typically following inflammation of the bronchial walls because of a viral or bacterial infection. In the early stage of the disease, the most common symptom is a chronic cough. However, some individuals may initially remain asymptomatic. As the infection grows, the bronchial wall is destroyed, resulting in an abscess. Non-reversible bronchiectasis results in saccular and varicose dilatations and constrictions which are permanent alterations to the bronchial tree. These individuals may also complain of pleuritic pain, demonstrate recurrent fevers, wheezing, and shortness of breath, or both on physical examination. Conventional chest radiography generally demonstrates increased bronchovascular markings and parallel lines outlining the dilated bronchi, or what we call tram lines, because of peribronchial fibrosis and inflammation and intrabronchial secretions. Occasionally, areas of honeycombing or cystic areas may be present. High-resolution CT scan is able to demonstrate bronchiectasis better than clinical findings and conventional radiography alone. It clearly shows dilated airways, extension of the bronchi as a result of the destruction of lung parenchyma, thickening of bronchial walls, and obstruction of airways either by a mucus plug or by air trapping. Next inflammatory disease is pulmonary tuberculosis, an infection caused by inhalation of Mycobacterium tuberculosis. M. tuberculosis organisms are captured by macrophages within the alveoli but are not killed. This creates a cell-mediated immune response which results in granulomatous lesions that infiltrate the tracheobronchial lesions. These lesions eventually result in necrosis, fibrous scarring, and calcifications which are visible on chest radiographs. Early pulmonary TB is asymptomatic in 90 to 95% of cases and may be identified only with a skin test. Signs appear when the lesion or nodular scars are large enough to be seen on a chest radiograph. Lesions are most commonly seen in the apical region of the chest, therefore the apicolordotic projection of the chest is useful in the evaluation of TB. The most common symptom is a morning cough producing minimal mucus. As the disease progresses, the cough becomes more productive and the patient may complain of dyspnea, and a spontaneous pneumothorax or pleural effusion may develop. Fibrocaseous TB is usually the course of the disease if the patient demonstrates active signs of TB. Necrosis is a prominent feature of the disease because its infiltration affects the lung parenchyma. This infiltration may expand and produce the formation of a cavity or what we call as cavitation. Infection spreads to the lobar or segmental bronchus, causing a persistent pneumonia resistant to antibiotic therapy. As a result, these individuals are especially susceptible to miliary tuberculosis, which occurs when large numbers of bacteria are picked up and carried via the bloodstream throughout the body. Miliary refers to its characteristic resemblance to millet seeds, which are small white grains. The bacteria are spread through sputum and airborne droplets expelled on coughing. Modern treatment of TB consists primarily of various chemotherapeutic agents that are effective and usually curative if the full course is taken. TB must be treated with at least 2 anti-tuberculous drugs, including both bactericidal and bacteriostatic drugs that act through different mechanisms. Chronic obstructive pulmonary disease refers to a group of disorders that cause chronic airway obstruction. The most common forms are chronic bronchitis and emphysema, which frequently coexist and may be associated with varying degrees of asthma and bronchiectasis, which is the two other causes of airway obstruction. The predominant risk factor associated with COPD is cigarette smoking. Air pollution and airborne chemical fumes, as well as inhalation of hazardous dust such as silica, may also increase the risk of COPD but are minimal compared with the effects of cigarette smoke. Chronic obstructive bronchitis most often arises from long-term heavy cigarette smoking or prolonged exposure to high levels of industrial air pollution. Chronic exposure to these respiratory irritants leads to hyperplasia of the mucus glands, hypertrophy of the smooth muscle, and thickening of the bronchial wall. Persistent cough and expectoration are the primary symptoms of chronic bronchitis. Additional signs and symptoms include wheezing, shortness of breath, and arterial hypoxemia, leading to right-sided heart hypertrophy and failure or cor pulmonale. Chest radiography may demonstrate hyperinflation of the lungs. Elimination of the causative agent is an important first step in treatment. Pulmonary rehabilitation, including breathing exercises and physical conditioning, helps manage the disease. Antibiotics may reduce the presence of infection. Adrenergic and anticholinergic bronchodilators are used to reduce bronchospasm, and oxygen therapy may be described for patients with severe hypoxemia. Emphysema is a condition in which the lungs alveoli become distended, usually from a loss of elasticity or interference with expiration. It is characterized by an increase in the air spaces distal to the terminal bronchioles with destruction of alveolar walls. The primary symptom of emphysema is dyspnea, which at first occurs only during exertion but eventually even at rest. In the early stages of emphysema, chest radiography may show normal results. However, as the disease progresses, hyperinflation results and the AP diameter of chest increases because of increased air in the lungs. Emphysema appears radiographically as a depressed or flattened diaphragm, abnormally radiolucent lungs, and an increased retrosternal airspace, or what we call barrel-shaped chest. Treatment for emphysema is much like that for chronic obstructive bronchitis. The goals are to alleviate the symptoms, treat any reversible elements, and prevent further progression of the disease if possible. Asthma is a chronic inflammation of the bronchial system resulting in airway obstruction and bronchial hyperresponsiveness. Its risk factors include exposure to allergens, air pollution, cigarette smoke, and recurrent viral respiratory infections. The signs and symptoms of asthma include intermittent attacks of coughing, wheezing, dyspnea, and chest tightness caused by airflow obstruction. Radiography plays a limited role in the diagnosis of asthma. Diagnosis is made through the assessment of ABGs and expiratory flow rates. Management of asthma most frequently includes the use of inhaled bronchodilators and oral corticosteroids and administration of oxygen. Pneumoconiosis result in pulmonary fibrosis from inhalation of foreign inorganic dust, most commonly from a particular work environment. The effects of an inhaled foreign material depend on its physical and chemical properties, the dose of the agent, and the site of deposition within the bronchial tree. The size of the dust particle inhaled is of particular importance. Most occupationally generated dust and those occurring naturally are too large to cause pneumoconiosis. Radiography assists in the detection and follow-up of this disease group. Lesions produced by the different pneumoconiosis vary but may include nodules, cavitation, and pleural thickening. The three primary types of pneumoconiosis are silicosis, anthracosis, and asbestosis. Treatment is focused on preventing infection, relieving any respiratory symptoms, and maintaining adequate oxygenation. Silicosis is the oldest known pneumoconiosis resulting from inhaling silica or quartz, and is common among miners, grinders, and sandblasters. It is the most widespread and most serious type of pneumoconiosis. This disease occurs following 10 to 30 years of exposure to silica dust. Phagocytes located within the bronchioles carry silica dust into the septa of the alveoli. In response to the foreign dust particles, the alveoli form large amounts of fibrous connective tissue, thus destroying normal lung tissue. This disease is clearly visible on conventional chest radiographs as multiple small, rounded opaque nodules throughout the lungs, resulting from the creation of fibrous tissue. With the exception of lung transplantation, no treatment exists for silicosis. Therefore, prevention through the use of protective masks and adequate ventilation is the key to controlling this occupational disease. Anthracosis, or the black lung disease, results from inhalation of coal dust over an extended period of about 20 years. As coal dust is deposited in the lung, coal macules develop around the bronchioles and cause their dilation. This dilation does not affect the alveoli or the airflow. Thus, impairment of the function of the lungs and the lung architecture is limited. Other than suppressing coal dust in the work environment to prevent anthracosis, no real treatment for anthracosis exists, and usually efforts to treat this condition are futile. Asbestosis results from the inhalation of asbestos dust, which causes chronic injury to the lungs. Asbestos dust is found in building materials and insulation. Radiographically, diffuse small irregular or linear opacities may be demonstrated in the lower lungs, and diaphragmatic pleural calcification suggests asbestosis. This disease may be prevented by effectively suppressing asbestos dust in the air of the work environment. A lung abscess is a localized area of dead necrotic lung tissue surrounded by inflammatory debris. These abscesses may result from periodontal disease, pneumonia, neoplasms, or other organisms that invade the lungs. Lung abscess is more common in the right lung because of the vertical orientation of the right main bronchus. When the abscess reaches a bronchus, it drains into the bronchus, forming a cavity which is visible on a chest radiograph. Clinical manifestations of a lung abscess include fever, cough, expectoration of pus, and foul sputum. Radiographically, an abscess generally appears as a lobar or segmental consolidation that appears or that becomes globular in shape as pus accumulates, or it may appear as a round, thick-walled capsule containing air and fluid. CT may be used to provide better anatomic information or to detect cavity formations. Empyemas consist of an accumulation of pus in the pleural cavity, usually caused by some primary lung infection. Treatment of an abscess and empyema enters on treatment of the primary condition causing it and including antibiotic therapy, chest physical therapy, postural drainage, and possible drainage of fluids via bronchoscopy. If the abscess is resistant to antibiotics, surgical resection of the abscess may be necessary, and in cases of multiple drug-resistant abscesses, the entire lobe may be surgically removed. Pleural effusion results when excess fluid collects in the pleural cavity. It is a frequent manifestation of serious thoracic disease, usually pulmonary or cardiac in origin. It should be regarded not as a disease entity, but rather as a sign of an important underlying condition. Pleural effusion may be caused by an inflammation, as in pleurisy, a pulmonary embolism, or a neoplasm. These pleural effusions are termed exudates. Pleural effusions may also result from microvascular changes, such as those associated with heart failure or ascites, and are termed transudates. A pleural effusion containing blood is called a hemothorax and most frequently follows trauma to the thorax or thoracic surgery. Conventional chest radiography is commonly used in the diagnosis of pleural effusion. The radiographic signs of pleural effusion include a blunting of the costophrenic angles, which is often best demonstrated on an erect left or erect lateral chest radiograph. The blunting occurs as part of the healing process, and the fibrous changes in the lung tissue may remain even after the pleural effusion has resolved. Lateral decubitus chest radiographs are also valuable because they can better demonstrate smaller amounts of fluid in the pleural space compared with either erect P radiographs or lateral chest radiographs. Thoracosynthesis or interventional techniques may be used to remove excess fluids for symptom alleviation and laboratory analysis, and to confirm the presence and type of fluid present in the pleural cavity. In the case of a hemothorax, blood rarely clots within the pleural cavity, so a water-sealed chest tube is placed within the pleural cavity to drain blood, provided the bleeding has stopped. Bronchial carcinoid tumors or adenomas are usually considered benign but are included in the World Health Organization's classification of lung cancer because they tend to invade local tissues and sometimes metastasize to regional lymph nodes. They are treated much like other malignant neoplasms. They are rare in occurrence, accounting for less than 1% of all lung tumors. The radiographic appearance of this neoplasm shows opacity, bronchial narrowing, obstruction, or both, and possible collapse of the affected segment of the lung. Bronchial obstruction is the most common presentation, and recurrent pneumonia within the same area of the lung, in combination with pleural pain, is a common occurrence in affected individuals. If the disease is discovered prior to metastases, surgical resection may be curative. Bronchogenic carcinoma, the most common fatal primary malignancy in the United States, accounts for over 90% of all lung tumors and has a very low 5-year survival rate. Lung cancers are divided into two major categories: non-small cell lung cancer and small cell lung cancer. The four main histologic types of bronchogenic cancer are squamous cell carcinoma, adenocarcinoma, undifferentiated large cell carcinoma, and undifferentiated small cell carcinoma. These tumors arise from epithelial tissue in the major bronchi near the hilar area and metastasize via the lymph nodes, the bloodstream, or both. Adenocarcinomas are the most common type of bronchogenic cancers, accounting for almost 40% of the cases diagnosed in the United States. In addition to a thorough patient history, chest radiography is essential for the diagnosis of bronchogenic carcinoma. The most common radiographic presentation of squamous cell carcinomas is airway obstruction caused by a unilateral hilar mass. However, the lesion must be larger than 6 mm to be visible on a conventional radiograph. As the tumor grows, it may occlude the bronchus, producing atelectasis and pneumonitis. These secondary effects provide more opacity radiographically than does the actual tumor. Adenocarcinomas usually are relatively small and are found in the peripheral regions of the lung parenchyma. The radiographic presentation of this neoplasm consists of a solitary radiopaque lung nodule, sometimes called a coin lesion. CT is essential in demonstrating nodules smaller than 6 mm, which are not visualized with conventional chest radiography. CT has the ability to show calcifications to help differentiate malignant and benign tumors of the lung and is useful in staging the disease by demonstrating the presence or absence of spread to the lymph nodes in the thoracic and upper abdominal areas. Malignant lesions are rarely calcified, whereas benign lesions generally have a calcified center. Staging bronchogenic carcinoma is critical to the selection of treatment of the disease. CT or PET can assist in determining metastases to the liver, brain, and adrenal glands, so it is now a common practice to include a portion of the upper abdomen on oncologic CT examinations of the chest and from the base of the skull through the midfemur on PET scans. This disease process may be treated with surgery, chemotherapy, external radiation therapy, brachytherapy, or any combination of these modalities depending on the type, location, and stage of disease. Chemotherapy, radiation therapy, or a combination of both may be administered before surgical resection, and radiation therapy may also be used for palliative treatment to control the pain association with skeletal metastases, spinal cord compression, or brain metastases. Pulmonary metastases are much more common than primary lung neoplasms. Many malignancies progress to pulmonary metastases, which are detectable on chest radiographs. Malignancy spreads through the lungs from a primary site via 5 different routes. First is through the bloodstream in hematogenous metastases. Second is through the lymph system in lymphogenous metastases. Third is by direct extension in local invasion. Fourth is through the tracheobronchial system in bronchogenic metastases. And fifth, which is rare, is by direct implantation from biopsies or other surgical procedures. Radiographically, these metastatic lesions appear as single or multiple rounded opacities throughout the lungs. Pulmonary metastasis from uterine cancer demonstrates multiple lesions with characteristic cotton ball appearance. CT is more sensitive than conventional chest radiography in the detection of small metastatic lesions. The most common primary sites for these tumors are the breast, the gastrointestinal tract, the female reproductive system, the prostate, skin, and the kidneys. As you can see on the radiograph, that is the lateral projection of the pulmonary metastasis resulting from uterine cancer, showing a cotton ball appearance. And that's all for our recorded lecture regarding the pathologies of the respiratory system. Thank you so much for listening.